All right, so we will get started. Welcome, everyone, and thank you for joining us today on this discussion on equity in newborn screening and looking at the current status and next steps for the newborn screening community. We are really excited to be able to have this conversation, and we know that there have been over the past probably year or so throughout healthcare, more attention to health disparities and issues of equity, and that conversation has, of course, been incorporated into the work of newborn screening. And recently, Amy Gaviglio, who I will introduce in a moment, has done some amazing analysis to really get a real sense of where we're starting out today in newborn screening, and more importantly, where we can go. So I will quickly introduce Amy, who is a certified genetic counselor and a public health genetics consultant who has been working in the newborn screening arena for the past 13 years. And I will say, I know I personally have learned so much from her. She is currently a consultant with the CDC, the Association of Public Health Laboratories, and with us at Expecting Health. And we are very happy and feel very lucky to have her expertise and her perspectives in the work that we do. So with that, I will actually turn it over to Amy to present to us some data, and then we will dive into a pretty active discussion.
Excellent. Thank you so much, Natasha. And thank you really for the opportunity to share some of the work that I've been doing with the Association of Public Health Laboratories, really beginning to assess questions around equity and disparities in newborn screening. Next slide. But before getting into some of our analysis, I want to make sure that we're all on the same page in the terminology that we are using. And while, like Natasha said, these terms are being used more and more in healthcare and public health, rarely in my experience are they ever actually explicitly defined. So because ambiguity in definitions can lead to delays or confusion in action, I think it's important for us to baseline. So let's start with the term health disparity. Health disparities are preventable differences in the burden of disease and our opportunities to achieve one's ideal health, and are often linked to social, economic, or environmental disadvantages. But not all health differences, of course, are health disparities. For example, a higher rate of concussions in NFL football players is not considered a health disparity because the difference is not really connected to the underlying and overarching concern of health disparities, which is social justice. You may also hear the term health inequity, which is more or less another way to say a health disparity. And again, here we are really focused on those differences in health outcomes that can ultimately be traced to unequal economic or social conditions that are systemic, avoidable, and unfair. Next slide. So then what do we mean when we use the term health equity? So in its broadest and simplest form, health equity means social justice in health. It means that no one is denied the possibility to be healthy because they belong to a group that has been historically, economically, or socially disadvantaged. And of course, health disparities and health equity are closely linked, as health disparities are essentially the metric by which we measure our progress or lack thereof towards health equity. Next slide. So I think many of you may already be familiar, but I did just want to describe quickly the NewSTEPs data repository, as this serves as the source of the data used in the analysis. So NewSTEPs is a part of the Association of Public Health Labs. It is a HRSA-funded initiative that attempts to collect newborn screening data from all newborn screening programs in the United States, primarily focusing on data that has to do with assessing defined kind of programmatic quality indicators, as well as collecting case level data. Submitting data into NewSTEPs is voluntary, and currently 46 newborn screening programs in the US do enter data into this repository. Next slide. So the data I am about to show you represents an analysis of cases that were in this NewSTEPs repository with birth dates between 2011 and mid-2021. I do need to note that this analysis only focused on those diseases or newborns identified through dried blood spot testing. So hearing screening and critical congenital heart disease or pulse oximetry screening are not included in the analysis. Next slide. So just quickly, some descriptive statistics. So during this time frame, there were just over 29,400 cases entered into NewSTEPs. Of these, 3,904, so just over 3,900 cases, were for diseases that are considered by the newborn screening community to be time critical. And what this means is time critical diseases are those that have the potential for life-threatening symptoms hours to days after birth. Whereas 25,000, which is actually the round number that it ended up being, were for time, what we consider time-sensitive conditions. So in newborn screening, time-sensitive conditions are still, of course, very clinically important diseases, but do not typically have the risk for life-threatening issues in the hours or days after birth. So of the just over, again, 29,400 cases examined, around 22,200 were those cases were identified on the first newborn screening specimen. And these are the cases I really honed in on for the analysis around timeliness. Next slide. So in terms of race ethnicity data available within NewSTEPs, unfortunately, we were missing this information for about a third of cases, and this is a limitation that we will discuss more at the end. But of the data we did have, there were 39 different race groupings reported, and for the purpose of this analysis, I condensed this into the 6 categories that are illustrated here. Next slide. All right, so let's start looking at the data. I'm also going to preface this by saying that in the interest of time, I am going to go through this relatively quickly, but if anyone has questions on methods, please email me. My email address will be at the end, and we can completely geek out together offline on statistical methods. Next slide. Okay, so I started by looking at those conditions that are considered time critical. And I understand that this is a bit of a busy slide, and you will see more of these slides coming up. So I want you to focus on the spark lines at the bottom, as this is a graphical representation of the medians after null values and outliers were removed. And what we are looking for here is how similar these bars are to each other. So here we can see, with the exception of the islander population, which I believe is likely due just to the very small sample size, the bars are pretty similar across the board. Next slide. But in addition to just looking at the median, we wanted to know if there were statistically significant differences across the entire data set in timeliness to diagnosis and timeliness to treatment or intervention between each race grouping. So again, you will see several of these tables throughout this presentation. So let me just kind of quickly walk you through what you are looking at. So this matrix shows you whether or not the birth to diagnosis times were statistically different when comparing each race grouping one-on-one against another one using a non-parametric test, as this data, of course, is not normally distributed. When you see NS, that means there were no statistical differences between these two races. And if you see an asterisk, there was a statistically significant difference. So also on each slide, I put a kind of a takeaway in the red box here. So if you only want to focus on one thing on the slide, this is where I'd look. So with that, we can see that there was no statistically significant differences between any of the race groups in time to diagnosis, at least for the time critical diseases. Next slide. So here we're looking at time to intervention, and in newborn screening, intervention is typically defined as the first event that changes the normal course of care for the baby. So this could be administration of treatment or things like recommending that the baby not fast and continues to eat. Again, here we see very little statistical difference, significance between race groupings. So why might this be for time critical conditions? I certainly have some thoughts on this. I do think it may have to do with the life-threatening nature of these diseases, but I'd be very curious to hear what others think, and we can certainly discuss further during Q&A. Next slide. Okay, so let's move on to the time-sensitive conditions. Again, if we focus in on those spark lines illustrating the medians, now we start to see a bit more variability than what we saw with the time-critical conditions. Next slide. And again, if we delve deeper into that data set, we start to see a lot more asterisks here illustrating significant differences. And ultimately, what we are seeing is that Black African American babies tend to have longer times to diagnosis when compared to Asian and white babies. I do want to note that I'm a bit hesitant to speak to the differences seen with the Native American and Islander populations here, as the numbers are quite low. But this is something I think certainly warrants us to delve into a bit more for future analysis. And next slide. So again, if we move to intervention, we start to see a pretty similar pattern. We see again that Black African American babies have longer times to intervention, really than all other races for those conditions that again are considered time sensitive. And again, we can talk about why this might be during the discussion. Next slide. So the last two analyses looked at diseases as a grouping. So grouped as time sensitive conditions, grouped as time critical conditions. But now we wanted to really delve into specific diseases to get rid of some of the variability between diseases. And I chose three to look at, starting with cystic fibrosis. And I chose cystic fibrosis because it is a disease predominantly associated with the white population. And I wanted to see how this might affect timeliness. So again, should be familiar with this graph now. We do see again quite a bit of variability in the medians.
We can wrap up this pretty quickly. I just make sure.
Thank you. When looking at the graphs here, we do see some of that variability. Next slide. And the extent of these differences are also apparent in the analysis here. Again, when we're comparing one race to another race, we see that indeed Black African American babies have longer times to diagnoses than Asian and white babies, with white babies having the fastest time to diagnosis for cystic fibrosis. Next slide. And this holds true for time to intervention as well, where white, Asian, and mixed babies all have faster times to intervention when compared to Black or African American babies. And I think in both cases, we can speculate on why this might be. It could be very well the utility of the variant panels that are being used by newborn screening programs. Most CF variant panels are very white-centric. It could be education issues. It could be, that pervasive myth that CF is only seen in the white population. And so there may be some communication gaps and education gaps on the need to follow up quickly in all babies. Next slide. So the next disease I looked at were the hemoglobinopathies. So like cystic fibrosis, I chose this disease as hemoglobinopathies are predominantly associated with the Black African American population. And so when I say hemoglobinopathies here, I'm including cases, so sickle cell, C disease, D disease, E hemoglobin, any of those disease findings, but I'm not including trait, sickle cell trait, or any of the hemoglobin traits here. And here we see something a bit interesting. The variability is not as robust, especially when you look at the bars for time to intervention. So next slide, let's look a little deeper. And this really kind of pans out further here. We see, interestingly, no difference in time to diagnosis between Black and African American babies and white babies. But it is important to note that Black African American babies are being diagnosed more quickly than Asian and mixed babies when it comes to hemoglobinopathies. Next slide. But if we look at time to intervention, any statistical differences actually go away. Again, I have some thoughts on why this might be, but really would be very interested in reactions from the audience here and further discussion on this when we have time. Next slide. So for the last disease, we chose congenital hypothyroidism. And we chose this one because for several reasons. One, it is one of the most common diseases that we pick up or detect in newborn screening. It is also one of the diseases that is often overseen by a primary care doctor rather than a specialist. And then the third reason is really that it is pan-ethnic, meaning it is not necessarily more prevalent in a certain race or ethnicity. So looking at the medians, this one's, I think, a little bit hard to see what might be going on. It's not fully clear kind of what variability there is. So again, if we go to the next slide and look a bit deeper in time from birth to diagnosis for congenital hypothyroidism, we do see that Black African-American babies have longer times to diagnoses than nearly all other races. Next slide. And by and large, this again holds true for time to intervention for congenital hypothyroidism. So again, Black African-American babies seem to have longer time to treatment or intervention than most of the other races when it comes to the disease of congenital hypothyroidism. Next slide. So I do want to point out a few limitations to the analysis that will be important for us to keep in mind during the discussion. The first is one that I've already mentioned. We are missing important race and ethnicity data for a large number of cases, about a third of our cases. And this makes it really difficult to do work on equity or to analyze disparities because it's really difficult to try to address what we can't assess. The second is understanding just the integrity and origin of the data. So it's not always clear from the data where the race ethnicity information is coming from. Likely it is different sources depending on the state. So it could be a checkbox on the newborn screening card. It could be coming from the birth defects registry. It could be coming from vital records. There's a number of kind of sources where it could be coming from. Likewise, it's not necessarily clear who the data represents. So is the race ethnicity that's being documented the race ethnicity of the baby? Is it of the mother? I would venture a guess that it's probably not reflecting the father. So really, understanding that is important as well. And additionally, I think at this time it's difficult to ensure that all states are using the same definitions of diagnosis and intervention. And certainly this could throw off dates. Certainly, we also recognize that race is a social construct and that self-reported race does not anywhere come close to adequately characterizing the lived experiences. And it is not taking, this analysis was unable to take into account other potential influencers, things like socioeconomic status or geography. Unfortunately, things like zip code or other SES factors like income are just not available within the NewSTEPs repository. And last, I want to think through, as we look at this and use statistical analyses, the potential difference between statistical significance and clinical significance. So in some cases, yes, receiving treatment maybe just 1 or 2 days later may not be deemed statistically significant, but it may very well be significant from a clinical perspective. And so thinking through how we can kind of better appreciate that distinction moving forward as well. Next slide. So with that, I am very much looking forward to discussing what this might mean and what next steps might look like, including what further analyses would be insightful. And next slide. I just need to say thank you to the APHL team, Sika Jalili Sari, for the support and feedback with the work, the NewSTEPs steering committee, who also provided just some fantastic feedback, and of course HRSA for their ongoing funding and support. And with that, Natasha, I think we can open it up.
Great. Thank you so much, Amy, for that. I know we'll have some questions that come through the chat, but just to kind of kick us off, when we talk about newborn screening, the purpose and goal of newborn screening, I think is always a good reminder to say newborn screening is not about a test. The goal of newborn screening is not to test as many kids as possible. It's to find kids who are at an elevated risk, assess that risk, and then get those kids into care as soon as possible. It's the whole piece, it's not just one. And so oftentimes I have heard, and I will say I have said, newborn screening is one of the most equitable public health programs in history. And while I think that is still a true statement, I think your data really shows that that is a much more nuanced statement than I think we care to. Not that we care to, but that we have given thought to before this point in time. So yes, every baby is able to get a newborn screening test, right? That is what we tend to think of as equality, and that is equal across the board. But then when we go that step further to equity of actually, I always think of equity as people getting what they need, and that is a bit more customized, so that's the difference. A test can be equally distributed, but the care is where equity may really come in terms of really having that match. And this data really shows that there may be some room for improvement there. I don't know if you wanted to just kind of comment on that and kind of how, from a newborn screening lens, how our, as a community, view on those words of equity and equality and all of that is evolving.
Yeah, I think I think it's a great point. And I think not to in any way to take away from the success of newborn screening, because I think compared to many healthcare initiatives, it has done much better in providing more equality and in some cases equity around access. So I think where we are seeing more of this discussion is really across the spectrum. And I know, Natasha, you and I have talked about this, but I think there's really no part of the newborn screening system that couldn't benefit from thinking about more equitable access, whether it is advocates' ability to even nominate a condition to newborn screening panels, and what does it take to do that? Research around newborn screening conditions and treatments for rare disease, even our testing. We know that even though we're like you said, the equality, we're providing everyone the same testing. It's not necessarily the best for everyone. I mentioned the CF variant panel that is going to be more useful for white babies. We also know some of our other analytes are either higher or lower in certain populations, which mean they're more at risk for false positive, false negative. And then what I showed today, I think just really highlights the issues as once we call that result out, how, the disparities in our healthcare system just come back, they come to light. We're not getting rid of that. So I think it's been a really important pivot for us to start acknowledging all the successes we've had, but being open to where we can continue to improve.
I think that's great and makes a lot of sense. As we've talked about and as you said, this is really a preliminary analysis. You listed the limitations, and including the type of data that's coming in, how reflective it is of the whole entire population, all of those pieces. And so just with that, I was wondering, from a data collection and data availability perspective, what do you see as some key next steps? I see that, there's been some comments in the chat, one of which is, even just looking at the percentage of babies who have received a newborn screen and those babies born. And I know that's something that's very near and dear to your heart. So even just starting there and, letting people know where we're at with that piece. And then where do we really have to go to be able to answer these questions and continue to improve the system, as opposed to just saying, I wonder what this might look like if we looked at it with only 60% of the potential data.
Yeah. So, I think this highlighted a few things. One was just how much we need to improve our data collection and newborn screening. I think the question about have we looked at percentage of children who receive a newborn screen versus number of babies born? Not all states can even do this because they're not linking to vital records. This is something I think is really important for a number of reasons. From a data perspective, of course, because having a denominator is important, but even from a like you said, an equity perspective, or making sure that babies aren't being missed and that we can follow up on those. So I think this just really highlighted how important it is for us to really start building better data connections. And we've seen this with the pandemic, how siloed public health data is, and how that causes problems in our ability to ask and answer questions. So I think that's going to be a huge piece. I would love to be able to say, in the US, this number of babies are getting screened, and we can't do that right now. I would say anecdotally, we can say that babies born out of the hospital setting tend to be more likely to refuse or miss newborn screening, but we can't quantify that at this point. I think in terms of kind of other next steps, I do think it's important for us to look at other individual disorders, maybe trying to look at this at a regional level to maybe try to get some of that geography question. That I see a great question in the chat box about between races with the same providers. We don't have provider information, so I can't answer that, but that's a fantastic question. And so trying to think through more what we can look at. I think outside of the analysis part, I really want us to focus on what we're seeing and kind of what are some things that we can maybe do right now. Like in CF, for example, I think simply training follow-up staff and primary care providers more on how to communicate CF results to non-white families is important. And I think the same, having just the same notification message for a CF newborn screening result, regardless of racial population, it just isn't appropriate. You really, like you said, need to tailor it. So I think there's just a lot of areas for us to continue to grow with this.
I've seen a couple questions come up, so just wanting to give you the opportunity to, if you could, again, define what time to diagnosis and meant within the context of this presentation.
Yeah, so this is a good question. I can tell you what we define it as within the registry, and it is a bit disease specific. So it's typically when you have the diagnostic confirmatory test results back. So it's not necessarily when they first get that notification, because at that point we don't know whether that result is going to be a true positive or false positive, but it is typically defined as when you get that confirmatory or diagnostic testing back, saying this is indeed an affected child. But again, I do want to asterisk that in terms of I can't be certain that everyone was using that definition when they put in their dates.
Great. And so I think, just to, if you could speak a little bit more to that in terms of the work that both through NewSTEPs to have some harmonized, maybe the right word, definitions around, those key terms and kind of the work done to that. And if there's just still more efforts for that, as there are more, whether we're talking about defining the time of diagnosis or the date of confirmatory testing, date of initiation of treatment, just kind of where that's solid and where is there more work to be done. Again, because we're not just talking about, one person in one state can control all of that. There are multiple people involved in all of these processes.
Yeah, I would say the word harmonization is a good one. And I think one we are really looking at in many respects in the newborn screening community, even just the disease panels notwithstanding, but from from a data perspective, it's very important. And I think we've all been defining things in very different ways, which has made it very difficult to compare. It's comparing apples to oranges, and we really need to be comparing apples to apples. So there's a couple efforts going on right now, and APHL is very involved in this as well. But looking at the case definitions, looking at what are states actually collecting to be able to say, yes, this is a case, and then really trying to, I think I hope in this coming year we'll really push on, this is how we're defining date of diagnosis for the purpose of reporting to the repository. Each individual program can keep metrics in their own way, but for the purpose of aggregation, we need to be using the same same definitions. And I think I see Barbara's comment in here, and this is getting exactly to the issue is, if I'm saying the date of diagnosis is when I get the confirmatory testing, if someone else is saying, well, it's when you got the notification, it's going to throw everything off. Likewise with intervention. So we need to harmonize this and agree, just for the purpose of reporting, this is how we're going to consider the date of diagnosis or date of intervention, probably on a disease by disease basis.
Great. So, let's say we had that magic wand and could do that.
I hope.
Then it doesn't end there, right? Because then we go to, yes, we have these definitions that are harmonized, and what's collected on one coast is the same and recorded in the same way as another coast. But then we get to just being able to do that actual collection. And so what are some of your ideas or thoughts, and open it up to those on the line to put in the chat. How do we know data collection is a barrier, you have to collect the data, and then data submission, you can say, is kind of another barrier, right? I always want to separate those two out. But when thinking about that data collection, how can we collect better data? And on the one hand, I want to say, without creating a larger burden for newborn screening programs. But on the other hand, I also want to say, if it is a larger burden, then how do we address that larger burden? Because there is still so much here that we can't fully answer, and then that just makes it hard, even from when the viewpoint I look at it. It makes it really hard to even educate if we don't have what some would think of as very basic numbers, like how many babies were screened. It's really hard to educate, and then the first question that someone would ask, you can't answer it. So that's just one example of that. But in terms of that data collection piece, what would make that better? Both if there's something easy, I don't think there's something easy, but lower burden, and then also if there is a larger burden, what that would look like.
Yeah, I mean, I think your distinction is important between data collection and then, data reporting. So I think, I do think in many cases this data is already being collected by other areas in public health, and I feel like I just keep saying it, but that connection to things like vital records, that not only gets us our denominator, but it often gets us, maybe not perfect, but better data around, parent education level, geography, those types of things that can be better used for these analyses. So I think, trying to leverage some of those types of opportunities. Certainly, we see a lot more in this, I think would get into both data collection and reporting, is just the use of automation, automating data collection and data transfer, either directly from an EMR or directly kind of having a data hub within public health. So I think there are a lot of opportunities out there that also use standardized vocab, standardized transfer protocols. So again, we get back to that standardization. But we could leverage other existing automated mechanisms in public health, like reportable, notifiable conditions. So I think, this isn't necessarily a novel problem, I think, in public health. I don't necessarily think it will require novel solutions, but it will require investment, I think, in the infrastructure to make it happen. But I think there are certainly ways where we can improve data collection just simply by looking to our colleagues within our agency who have some of this data. And then, again, I'm going to say the word harmonization again, probably not the last time, but if we're all asking the same thing across the country, I think it makes it more compelling for EMR vendors to build solutions. It makes it easier for people to report if they're not having to kind of report in different ways for each individual state program.
Great. Yeah, I think that's really helpful. And there's a comment that came up that, just to give more context, that sometimes it's hard to figure out who a baby's actual provider is compared to who's listed, who may be the person who's actually was in the hospital when the baby was born, and that is, a thing. And there are many reasons why that's listed, right? We don't know. Sometimes, I think in some hospitals, you just put the pediatrician who's on call that name on.
Exactly.
Some families don't know who their provider is going to be, either because doesn't mean they haven't researched it. It just means they're part of a practice. And so they're going to show, they know which address they're going to go to for, that third day well baby visit, but that's all they know. And that there may be a lot of other reasons too why that information isn't there. And that might seem like one really small piece, but then that could add, another day to really making those points of contact. I don't know if you want to talk about either that particular example or others similar in terms of getting a bit to the why there may be.
No, I think this is an important point. And I know, any follow-up staff that's on this call right now is, I'm sure, nodding their heads furiously of how this can delay notification. So a couple things. We did in the analysis try to kind of piece out the entire process. So we did look at birth to specimen collection, birth to receipt by the lab, birth to report of the positive result, and then birth to diagnosis, birth to intervention, which is what I focused on today. The first three really did not have statistically significant differences. So there is something else going on, I think, above and beyond the potential delay that can happen if you're trying to notify. That being said, I think, that question and that point highlights how important it is to look at the different pieces. Because if you just look at time to diagnosis from birth, there are a number of places where things could have gone wrong. And so if you don't delve in and look kind of at all the different processes and pieces along the way, it makes it very difficult to target any intervention. So I think that's for me, just highlighted, how important it is to have really delve down in the processes to get to that why question. Because if you could think it's one thing, design an intervention and make no difference if you don't delve down further.
Yeah. I want to bring up, we've talked about, data collection is hard, data submission is difficult. And though newborn screening is almost a 60-year-old program, which is wild to think. And it has so many things that are unique about it, but it isn't the only public health program, and it actually isn't even the only system that collects data very early on in childhood, you could say, right, during that newborn period. And so I'm talking about EDDI. And that EDDI has, this a range of different infrastructures and pieces in place that seem to have more actual requirements in terms of data submission and submitting data in certain ways. I know that there's a process in terms of, as states receive funding, they submit data to CDC and to HRSA. Can you talk a bit about, and I know that I know you're very knowledgeable about a lot of things, but I don't want to assume that you know everything about everything. But from what you know and from your parent perspective, kind of a little bit of compare and contrast to EDDI, in terms of data, and if there are maybe either lessons learned or strategies that we could gain from a system like Eddie or others that you know of that would be helpful in us actually being able to answer some of these
Yeah.
questions.
I'll do my best. I know a little bit about Eddie. I'm certainly not as familiar as Allison, who I think is pointing out this question. It's a great point. I think we have a lot to learn from Eddie in terms of their focus on data collection. And really, I think in my experience, they've focused on things like loss to follow-up or versus a loss to documentation, and really thinking through that kind of entire experience. I think the other thing that Eddie has done really well that I think we could learn from is that from the beginning, at least my understanding is that they really saw it as a complete system. It wasn't just the newborn hearing screen. It was the follow-up, it was the early intervention, it was, so I think the initial design of the data collection was really around, not just the test itself, but where these kids end up and are they getting services. And so I think in that respect, we have, I think we could look to Eddie a lot. There are differences. You mentioned the funding piece and some of the requirements around funding, which it can be very difficult to report data when you don't have to, and you're screening babies every day. I fully appreciate that and understand that. I think the other thing that's been interesting is, not that many newborn screening programs are integrated with their Eddie programs or their CCHD programs as well. And so I think that's another area of opportunity for leveraging some of the more robust data collection systems. And so, yeah, I think we could learn a lot from the Eddie model in looking at kind of screening as a system.
Yeah, and I think that that's an important point in terms of I kind of see the newborn screening system grew in a different way than the Eddie system grew. So kind of Eddie grew, from my viewpoint, it's just one person's opinion, right? From kind of really looking at that entire system, that entire spectrum, and almost it really being mapped to that family, what we would call a family experience in terms of all the different points and where they are along that point. And I think a lot of newborn screening has been really detailed and mapped around what happens at the lab and follow-up side in terms of almost like the sample, right? The sample and the results of that sample.
Yep.
And really mapping that out and doing that for many, many conditions, and understanding the nuances between those different conditions in terms of how they're detected, what's the technology used for it, all of that, the categorization of them from time critical, time sensitive, all the detail in that part of the system. And at the same time, we always say newborn screening is a system. So then there's all this other piece too of, okay, there are results, and then what happens? What does that trigger in different places, whether on the clinical side, the family side, even in the state maternal and child health department agency side, what are the things that get triggered? And there may be, I think, like you said, some opportunity to see what is similar between these two systems and what is different, and what would those build outs really look like. And of course, there are no two things that are exactly the same. So it's not to say that everything you can just replicate or just copy and paste, but there are just different approaches, right? And different approaches get you to different places. So I think that's just important to know.
Yeah, the integration, I think, could be really beneficial for the patients as well. It's not uncommon for a dried blood spot condition to present with hearing loss, for example. And if you can coordinate that care better, same with heart disease, I think that there's value to the patient experience and integration as well, above and beyond data collection.
Yeah. There was one item that came up that I think is a good a hard question, but I think a good one in terms of, how do we really get these conversations about health equity started in newborn screening programs? And what does that really mean? I think we know that, well, health and healthcare overall has a lot going on right now, let alone health from a public health domain, let alone a newborn screening program, right? And discussions about health equity are always hard. I think they're always hard if you're really doing them well, and because it's digging deep, and it's asking some hard questions, and it isn't necessarily about, someone or some institution did something really, really right or really, really wrong. I think a lot of times the starting off point is just, well, where are we now? Is this good enough? Or do we have higher hopes and higher expectations for ourselves and the people that we serve? And if so, what are the steps to get there? And so I think, the work that you've done, Amy, is really, it's just so impressive that you kind of took this on to say, well, let me look and see. I think that is such a first and an important first step to dig and to see what lines up and what doesn't. But, how do we continue to have that conversation and it not just be a data conversation, right? But really a conversation about health equity in all the different parts of the newborn screening system. What, from your viewpoint, as someone who's worked in lots of those parts of that system, what would be helpful to have that real, robust, and impactful conversation on health equity?
Yeah, that is a great question. I think it starts with just the acknowledgement again that this doesn't take away from the good work that is being done, but I think we should always be asking ourselves where we can do better and how we can improve. And I think, if we go back to really the ultimate goal of newborn screening is to improve health outcomes through early detection and intervention. And so I think if we always continue to go back to that goal, that gives us a framework, and that is what our goal is, and we should be held accountable to ourselves to meet that goal and to assess that goal, and to make sure that goal is being reached for every child, regardless of the way they look, where they live. So I think for me, just kind of always coming back to the goal and mission of newborn screening is a good baseline. I think it is easier. I saw a comment here. I think it is easier often for follow-up staff, those individuals who are working on the results to think about this, because they are dealing with the human side a little bit more. Whereas in the lab, they're getting a piece of paper in, and sometimes they're getting hundreds to thousands of those a day, and there can be a disconnect, understandably so. So I think, always, again, we're coming back to the human side of it, and focusing on that. But, I think it really does come down to mapping out processes and I know I don't want to condense this or reduce this to a data conversation, but sometimes data speaks a lot, and that really helps focus you as well. So I think would be a bit of a combination. I hope just having more conversations like this get people a little bit more comfortable talking about it and motivated to look at it too. So I think forums like this are really helpful.
Yeah, no, I agree. And I think, as we said in the description of this webinar, that this is a start to a conversation. It's not the end all be all, but being able to have a conversation like this for an hour hopefully helps everyone who's on the line listening to us go back to their agencies and institutions and pick up the conversation there, and to see, okay, well, what does this look like? I've seen a couple of comments that have come through the chat. I really appreciate people keeping the chat
Great.
going. It's great. Thinking about, how do families really connect to care? And I I think about this so often. It's like we hear about a sample coming in, running the sample, you getting the results, you calling it out to, the provider, and then the family goes and sees a specialist. And I think just year over year, I realize like how big of a gap that is of just being like the provider gets results and then the family sees a specialist and gets intervention. And it's like that, and that it's almost like a black box of like, well, what does that really mean? Like, who's coordinating that? And of course, we've done focus groups and research with some families who've really struggled in that in terms of trying to figure out, is someone going to call me? Do I need to call someone? So I think, again, even in that sense, really getting a better sense of what are the true, not just how is it supposed to work, but what are the true experiences there can really help us answer some of these questions too. And again, not necessarily saying, there's a difference if someone calls and leaves a message for a family saying like, hey, we got this result. It's a little funny, but you don't need to worry about it. Like we're going to follow up and get back to you. That's a really the response to that is going to be really different than someone saying, I'd really like to see you, or I need to speak to you soon, or you're actually going to get a phone call from a specialist to take these next steps over the course of the next day or two. That's a really different that's a different type of activation, right? And so I think even us really getting a sense of that and seeing if that's different, either different depending on condition, which may be appropriate, or maybe different based off of other reasons, which may not be as appropriate, will also help us kind of answer these questions. But again, it's back to that research or, QI work throughout the system, like all the way till we know that kid is not just in care, but is in good, solid care and is doing well. And that takes quite a bit of infrastructure. But I don't know, as you've gone through some of the other comments around, getting a sense of those connections to specialists and to care, anything that comes up for you, Amy?
Yeah, I think it is a good point. Many of these diseases are being seen by specialists who are in tertiary care centers, which tend to be in urban environments. If you're in a big state, that can mean traveling hours. Hours could be an overnight trip. So I think there have been some groups that have looked at this as well, but absolutely. I think that is a concern. It is not possible or easy for everyone to take a trip that long. Maybe they don't even have, maybe they're no transportation, not often public transportation, and from 2 hours away. So I think that is something we really need to think about, and figuring out how to equip the primary care providers, the families, and the specialists with tools to facilitate that. It will be interesting to see how the expansion of telehealth maybe helps with some of this, or what can be done remotely to try to appease or get rid of some of this. But I think the access to specialists is very important. I don't want to just limit it to geography, though. I know even families who live in the same city as the specialist can have issues getting to the specialist too. So I don't want us to just say it's a rural urban issue, because I think then we miss the opportunity to help other individuals, especially recent refugees who maybe don't understand the transport system, how to get there. They have multiple kids that they now need to bring to appointments. So making sure that we kind of keep that population in mind as well will be important.
Yeah, I think that's really important. And again, another place where data would be really helpful to see, to compare and contrast. Here in DC, one of the big things that we've heard a lot about in the past, 2 years is because of certain hospitals closing in certain neighborhoods, it can take someone 2 hours to go and see and get prenatal care on public transportation. And that's in DC. And we know DC is we're small, but we're still a mighty area. But even in a location like that, where you would think everything is so close, that may not be the reality when someone's actually trying to get care. There was one other item I wanted to bring up, kind of tying to the comment that came up earlier around kind of the difference between equality and equity. I think sometimes in newborn screening, we don't talk too much about costs, but there are costs, both to the system and to families. And we know, if you ask any family in this country, you can't talk about healthcare without talking about insurance coverage. And so I just didn't know if you either had any comments on that, or if you knew of any initiatives that are going on to really kind of think more or look more at how insurance plays a role in kind of what I consider achieving the real dream of newborn screening, which is getting to that care and changing health outcomes. So just anything on that topic that you have.
Um, yeah, this is a big one. I'm not aware of any direct initiatives to really look at this. I think it can be difficult. I think there are potential good avenues looking at all claims databases. Those types of things can be helpful. I know, in terms of coverage for certain treatments, there have been initiatives around medical foods and formulas, which, remains an issue 60 years later for our first conditions. I do know locally, we have some bills going through in Minnesota to allow individuals with rare diseases to make more decisions on going to see out of network providers who may be specialists in their disease, and having insurance cover that. So I'm not certain on any global policies, but I think policies like that, out of network providers, telehealth policies, coverage around that will be it will be important continuously. And I think will be interesting to see too, as many of our new conditions have treatments with quite high price tags. And so how that starts to factor in as well. But yeah, insurance is a big one.
Yeah. Yes, it definitely is. Well, thank you so much for your time today, Amy, and the data and the information, and also just the conversation about, I think there are a lot of things that we've brought up today that there may not be clear cut answers and solutions, but I think being able to call out the question and to say, is this something that we could do a little bit better?
Yeah.
And what does that look like? And how do we connect with each other to do that is a great starting off point. I also want to say thank you to everyone in the chat who kept that going. There was some great information shared about the histories of the different programs that we're talking about. I think there was an article that was shared also, and just more information. So that was great. Thank you to everyone who was active there. And we will, once we have the recording available, we will let you all know. But with that, thank you so much. And I know that Amy's always Amy's always willing to answer questions from anyone. So I'm just going to offer that up for her, offer up her time for herself. But also any kind of ideas or project ideas or areas that you would like to see us at Expecting Health and Baby's First Test delve into, please let us know. We build our work off of what we hear from the community, and that is you. So again, thank you so much for joining us today, and wishing everyone a great rest of the week.